honor this lecture is given was an outstanding ophthalmologist in Lexington, Kentucky for many years. After completing his undergraduate and medical degree at the University of Louisville, he trained in ophthalmology at the University of Cincinnati. Among the honors he received was election to Alpha Omega Alpha. His surgical skills were enhanced by his service in the Korean War and experience he valued developing a sense of compassion and willingness to make an extra effort in administering to his patients. Throughout his career, Dr. Stambaugh always was eager to apply new and innovative technology to his practice, while never losing sight of the physical, emotional, and spiritual needs of his patients. He enjoyed teaching and served on the voluntary faculty at the University of Kentucky, and during his later years of his professional life, which was extended by a heart transplant, Dr. Stambaugh became increasingly concerned about a variety of ethical issues, including the rapidly occurring changes in medicine and the impact of societal changes on medical profession and the value of individuals needing care. The Stambaugh family ensures that the ethical issues of importance to Dr. Stambaugh are addressed through their endowment to this lecture series. Please bear in mind that it is a special gift when the family sets aside literally scores of thousands of dollars to allow for an endowment like this, and we owe the Stambaugh family a debt of thanks. For that, I'm sure that Dr. Stambaugh, were he with us today, would be very pleased to hear Dr. Malek speak on honesty and obfuscation in medical training. Please let us welcome Dr. Malek.
Thank you. Thank you, David, for the invitation and for the kind hospitality. I'm very pleased to be here to talk with you this afternoon about this, what I think is at least an important topic. There we go. All right, so we will spend the next 45 minutes or so thinking a little bit about trainee involvement in patient care. And in particular, I'm going to offer some reasons why we would think about being honest with patients about trainee involvement in patient care. And then consider some justifications that I've heard over the years for why we might want to be a little bit less than honest about the role that trainees play in patient care. Thirdly, I'm going to try to look at what I think is actually the source of this problem, an underlying issue about the role of medical students, and then suggest that we have a need for some new norms, perhaps a paradigm shift in the way that we think about medical trainees and their involvement with our care of patients. So just to be clear about what types of things I'm talking about today, when I say honesty with respect to patients and patient care, I don't just mean being honest about the role of the person in the medical team, just the fact that they are a medical student or an intern or a resident, but also a little bit more specifics about the extent of the experience that that person may have had with a particular procedure. I'm not necessarily saying that we have to tell every patient that we come across that this is the third time I have done this procedure or the second time, but just a little bit more information than the general role that that person may play on the team. We want to be honest with patients about specific activities that will be carried out. Will the person be just attending? Right? Will the trainee be holding the retractor? Will the trainee be doing the surgery? And finally, who will be supervising and how much supervision will be involved? Okay, so when I'm talking about honesty, I'm talking about a broad scope of issues that patients might want to know about. Secondly, I want to be clear about who we're discussing here. We're not just talking about honesty on the part of medical students. I think that's the first thing that comes to mind for many of us. But also honesty on the part of resident physicians, as well as attending physicians. Particularly resident physicians and attending physicians have two different roles here. First of all, in the role that they play as a supervisor, someone who is introducing medical students to patients, as well as their own practice. Right? We don't typically think of attending physicians as someone who should be completely transparent that this is the first time they have done a particular procedure. But I think that that's something we should at least consider and be aware of, the ethical implications of that type of scenario. I'm going to show you quite a bit of data today, or I've tried to distill a bunch of data. Most of the data that we have about honesty with patient care and medical training comes from the surgical literature, from the obstetrics and gynecology literature, and from the emergency department literature. Now, I think that's probably because these happen to be procedure-heavy specialties or areas. There's very little out there that comes from sort of a more general perspective, from a family medicine, from a pediatrics perspective. But I think that some of the same principles and ideas would still apply nonetheless. Finally, the data that I'm going to show you is kind of a mixture of data about medical students and medical residents. And rather than trying to split it all out and try to come to conclusions about the differences between those two, I think most of the message in the end can sort of apply to both. So I've kind of lumped it together, and I hope you'll forgive me for that. All right, so the reasons that we should think seriously about being honest with patients are pretty fundamental. I'm sure everybody in this room is very familiar with the principle of respect for patient autonomy. Informed consent is the bedrock, or at least an important bedrock of medical ethics. And even undergraduate students know that getting informed consent from patients is a very important consideration. So informed consent, adequate informed consent, or valid informed consent requires information that is material to the decision at hand be given to a patient. And it doesn't seem to be too much of a stretch to argue that patients can reasonably find trainee status to be material information. As I'll talk about a little bit later, patients sometimes do change their mind about whether they would allow a trainee to participate in their care, which shows that it is material information. So this isn't a very long, involved ethical argument. I'm a philosopher. I've written much longer arguments than this one, but this one seems pretty straightforward out there, and it's pretty hard to argue against. There's also a pretty good consensus that this is a good ethical argument. The AMA has written an opinion, this was in 2001, so it's not a new concept, saying that medical students involved with patient care, that patients should be informed of the identity and training of the individuals involved in their care, that all healthcare professionals share the responsibility for properly identifying themselves. So it's not just the student's responsibility, it's not just the resident or the attending supervisor responsibility, but everybody's responsibility. And finally, that students and supervisors should refrain from using terms that may be confusing when describing the training level of students. Okay, so there's not a lot of ambiguity here, I think. However, I'm going to relate to you an experience from one of my students. Maybe this is something that happens just at ECU, at the Brody School of Medicine. Maybe here in Louisville, Louisville, is that right? Louisville? you have this all under control, but anecdotally, I've heard no anecdotes from this school in particular, I'm not saying that, but from around the country, I don't think this is an unusual experience that my student I've changed his name to protect the innocent or guilty, but Osama was a student who came to me a number of years ago. I do clerkship education sessions with our third-year students in the OB/GYN rotation. And after one of the ethics sessions, my student came and made an appointment and said, you know, I'm really bothered by this, by the experience that I've had in this clerkship. He said, I have been introduced as doctor. I have been discouraged from talking with my patients about my level of training, about the fact that I am a medical student. And I have been sort of put in a position where my attending physician or my resident says, sort of, here you go, this is so-and-so will now be doing the exam without any type of introduction or permission from the student, and he really felt, or from the patient, and he felt very uncomfortable about that. He had gone beyond just feeling uncomfortable, though, to have come up with a plan. What he wanted to do was to put up posters in the waiting rooms at our hospital that said, basically, thank you for allowing us to participate in your care. you know, the students of the Brody School of Medicine. I thought that this is, maybe needs a little refining, but I thought this was a reasonable proposal. We started talking about it and talking to who we would need to, get permission from, how we would get these sorts of things designed. Somehow, and I don't know exactly how this happened, risk management became involved. And they set up a meeting time with myself and the student and said, we can't do this. We're not doing this. And just basically kind of left it at that. There was a little bit of explanation about how it might make patients uncomfortable, but there wasn't a very robust explanation. So here's my student feeling like he had really been morally compromised, was trying to do the right thing about it, and was really meeting brick walls pretty much every way that he went. Right. Unfortunately, the data show that Osama is not alone in his experience. There are some recent studies that have come out. On one study of surgeons by a surgeon named Knifed, not kidding about that, 83% of surgeons do not volunteer information about resident involvement in surgeries. They will only disclose if it is explicitly asked of them what the residents would be doing as part of the surgery. Another study, it's more of a qualitative study, so the numbers aren't exactly statistically significant, but showed that after interviews with 200 medical students, 71 offered descriptions or anecdotes about situations in which those students were asked to perform intimate examinations or procedures without consent. And finally, another study showed that 77% and 47% of medical students had been present at a medical interview or performed an examination, respectively, without patient consent. Some of you may have been familiar with, there was a bit of a kerfuffle in about 2003, 2004, when some data came out about intimate exams on anesthetized patients, and it made it into some of the public newspapers, and people got pretty upset about this, realizing, I'm seeing some nods, so some of you are familiar with this. And I think I had kind of been under the impression that after that came out, it wasn't really done anymore. But recent data has shown otherwise. There's a new study that came out just last year. This, again, is a qualitative study, not so much with statistical analysis, but that students regularly use the term student doctor to sort of cover up their true role as a medical student. And finally, there's some really interesting research, which is a little bit older, and this Louisville article is actually one of the ones that ended up sort of generating that controversy in the early 2000s. Data shows that in situations where the patient is anesthetized, when the students have gotten farther along in their medical training, and in particular after completing a clerkship in OBGYN, students, they've shown a difference in the importance that students report placing on informing patients about their medical training level. All right, so unfortunately, this doesn't seem to be a completely isolated situation. Now, I imagine some of you are sitting there thinking, yep, this all sounds good, honesty is important, obfuscation is a problem, but what about? So I'm going to try to see if I can anticipate some of those buts and what about. Now, maybe not, maybe I'm preaching to the choir here, so you're all on board with me, but I've heard a lot of different objections or justifications for why we should be less than honest with patients. First of all, surgeons in particular, this is a different article by the same author about surgeons. She found that explaining the involvement of medical trainees takes too much time, and that is the primary reason why surgeons do not explain it during an informed consent procedure. This seems to be a deeply problematic argument. It's not one that's going to hold a lot of weight in ethical circles, certainly. just because something is complicated and difficult doesn't mean we don't do it. It's a pragmatic consideration that we can try to find ways to get around. It's not an ethical justification for not informing patients. There are a number of approaches that have been attempted by people in the literature, for example, having a patient advocate being the one talking with patients about that, having nurses or medical students. It doesn't have to be the attending physician taking time out of their day to having that discussion. A second justification that I have heard for obfuscation about patient student status is that patients don't really want to know that they're participating in trials. Maybe they think they want to know, but they don't really want to know. It's just better if everybody does. If they don't know, they won't get so stressed about it. It won't make them uncomfortable. Let's just not make a big deal about it. Well, there's been study after study showing that patients overwhelmingly want to have this information. And here are just a couple recent studies, but there's quite a number of good projects out there that confirm this result. Patients wanted to be informed about resident participation in a major or minor surgery 96% and 88% of the time. And 92% of those patients in this study wanted to be informed if it was the first time that a trainee was performing a procedure. And again, this is very recent data. Another study, an older study, found that 80% people were directly asked, how would you feel if you found out that you had participated in medical training without your permission? And 80% said that they would feel wronged. Not just upset. There's other data that said they would say they felt upset, but they would feel wronged, which is a very morally weighty word, if they had participated in medical training without their permission. Anecdotally, I am not a physician, so I have not undergone the physician training, so I tend to see these things a little bit more from the side of a patient. I brought my then 2-year-old son into the hospital. He was having trouble breathing and he needed steroids. They went to go give him an IV, and this medical trainee came in. I think it might have been an EMT. I don't think it was actually a physician. He was literally shaking. He was trying to rip the tape off, and there was someone who was trying to help him, and he had to try a number of times to get it in, and finally he did, and then he couldn't get the tape on, and the tape was like all stuck together. It was this big mess. And it was clear that he had not done this before or hadn't done it many times. And even though it's my 2-year-old son, who I love very dearly and would want to protect, I would have let him have a chance to do it if he had asked. But when I left, I felt wronged. I felt like he should have at least just explained to me what was going on. So I don't think this idea that patients don't really want to know is a particularly convincing argument either. All right, now here's one that maybe seems like it has a little bit more credence. Maybe they have given implicit consent by seeking treatment at a teaching facility. Some people sort of try to support this argument by saying that not only have they given implicit consent, but they've also given explicit consent when they are admitted to the hospital and they get that 7-page document that they sign their name on the bottom. One of those little lines in there says, you will be treated by members of our medical team, including physicians, residents, students, something like that. Now, maybe that is permission in a legal sense, but that's certainly not informed consent as we think about it in ethics. So what about this idea of implicit consent? Well, again, we see numerous studies showing that patients do not understand how the medical system works. When, probably for most of you, if you see somebody in a short white coat, that automatically means something to you. Okay, for the vast majority of patients, that does not automatically mean anything to them. So they really have a fundamental understanding that, again, I didn't even list some of the specific data here, but people do not understand what a resident is. Some people think that residents supervise attendings. Many people don't understand that residents actually have to be supervised. So there's substantive data to show that people do not understand medical training. Here is just a little bit of data. Of patients surveyed at a university hospital, only 30% of those surveyed said that they should expect to participate in medical training without being asked. And 38% agreed that they must actively decline to participate in training. So the majority of patients, even at a university hospital, disagree with the idea that they have implicitly given their consent by showing up at a teaching facility. We could go on and on about this as a concerns about this reason having to do with justice and fairness, right? Some people don't have any other option. This is the only place they can go to seek care. But I think there is pretty strong data to show that patients haven't given anything like informed consent just by showing up at a teaching hospital, and that they do not expect that they will be used in medical training without their permission. All right. Now, finally, maybe now we're getting down to something that might be close to a good reason for obfuscation. Attendings and residents and medical students all have an interest in promoting medical education. They're concerned that patients will refuse to allow trainees to be involved if they're too honest, if they're too open with the level of training. And there is actually evidence that supports this to some degree. One recent study found that more patients who come to the emergency department do refuse to be seen by students and interns when it has been explained to them what the level of training of students and interns is. All right, so this is just one study. Again, there are some other studies that show similar things, that there are decreases in willingness to participate when permission is asked and when people are more transparent about their level of training. However, I think it's worth noting that the numbers here are not, it's not as if the number goes from 10% refuse to 80% refuse, right? We are increasing by 60 or 70%, but it's from 17% to 25% refusal, and from 8% to 13%. So even though these are significant increases percentage-wise, the numbers that we're talking about, we're still talking about the vast majority of people as being willing to allow trainees to participate in their care. Here's a couple of other studies that have done similar studies, not so much comparing the difference, but just asking patients. And some of these are a little tough because some of them are hypothetical as opposed to actual. It's a little easier to say, hypothetically, I would allow a trainee to participate. But in this one, they were saying that patients did say that they would allow a trainee to do their very first sutures, not just to be a trainee and do sutures, but their first sutures, their first intubation, and even their first lumbar puncture. Okay, so we're not in the majority anymore when we get to lumbar punctures, but the vast majority of people are willing. I mean, many people are willing. A substantial number of people are willing to allow trainees to participate in their care. This one other more recent study showed that patients undergoing cataract surgery would allow a resident to assist. 83% would allow a resident to assist, and 49% would allow a resident to perform surgery, a cataract surgery. All right. So what we're seeing here is that there might be, it might make medical education a little bit more challenging. The numbers might be a little harder to get, but we're still seeing very substantive numbers of people willing to participate in medical care. So I don't know whether I've convinced you all whether this type of obfuscation can be justified. I think there are good reasons to be skeptical about all of those most common objections or most common excuses that people give for not being honest with patients about the level of training. So if that's true, why do we continue taking this approach? All right. And here's where we get to something that I think is a little more substantive, a little more interesting. It might be because people have misperceptions about how often patients will say yes. It might be that some medical students have had that surgery that they really wanted in on and they got refused. Okay, so there could be some of that going on. In general, I think there is a lack of education about these things. This data is not something that gets a lot of press, especially in medical schools. And finally, where there are policies like the AMA policy, and many schools have similar policies, nobody is making sure that these policies are enforced. They're out there, they're on the books because it looks good for the accrediting agencies, things like that. And some people might really follow them, but there's really little, there's no infrastructure to make sure that those policies are followed. I think the real issue, and what I'm going to sort of propose, is that we as a medical culture have a negative perception of the role of medical students. Okay, we sort of overemphasize the risks that are associated with participation of medical students, medical residents, and fail to recognize that there are many benefits associated with that care, or including those trainees as part of the team. So there's been a lot of literature written about risks to patients and how do we justify risks to patients. How do we sleep at night knowing that we are putting patients at risk in order to bring about this benefit of education to society or to future patients? How do we balance those two goods? And I am not denying at all that that is an important consideration. It's something that we need to keep in the forefront of our mind. However, very little attention has been given to the value that medical trainees can bring to a medical team. And there is a little bit of data about this. Students have time to talk to patients. Students usually only are assigned to one, maybe two patients at a time. So they can go in and have those conversations with those patients. They can go do the research. They can serve as a liaison between the two, between the other members of the team and the patient. They can translate what the attending or the resident may have said to the patient. Okay. That is an important benefit for patients that we just kind of gloss over, I think, typically when we're thinking about medical training. I've had a couple of wonderful examples of students who actually, because they had just read that article, in their studies, found a diagnosis that the attendings and residents, it was unusual. You know how everyone wants to be the one to find that crazy case. Like, I've heard 2 or 3 examples in my clerkship conversations where students were the ones who came up with an important diagnosis. So they are offering time and attention and extra consideration that patients might not get otherwise. All right, so it's not only that patients can contribute, but that students can contribute in these ways. It might be harder for residents. That argument might be harder for residents, right? Residents are more under the gun and they don't have as much of that free time, but that applies more for students. Patients reported that they had benefited. Okay, they felt like the medical team as a whole spent more time with them when trainees were involved. They felt like their case was analyzed more carefully, that more people were involved in it, and that sort of more systematic consideration was given to their problem. So patients actually felt like most often they benefited from trainee participation. And they also reported satisfaction from contributing, sort of in the same way that research subjects report satisfaction for contributing. Even when it's something that puts them at risk, they know that they're helping other people. And no matter how skeptical we may be sometimes, like, that is something that motivates people and makes them feel good about their experiences, especially when patients can be in very vulnerable situations, trying to find meaning in something, a hardship that has come to them. Having an opportunity like this can empower them in ways that they might feel very disempowered otherwise. All right, so I think it's really important that we take this type of benefit into account when we are thinking about the role that the medical student can play in the medical team. All right, so here I'm kind of, maybe I'm getting a little idealistic, okay, but what I think we need to see is sort of a paradigm shift. I would like to see medical students and medical residents see their role not with embarrassment, not to try to hide the fact that they are a medical student, but instead with humility. Right? Aristotle talks about virtues as being a mean between two extremes. Okay, humility as a virtue is having sort of the proper regard for your own worth and your own contribution. So I'm not necessarily saying we want medical students to kind of think that they are like end all and be all of medical care. That's not necessarily what I'm suggesting, but to properly value the contributions that they can make while at the same time being modest about their clinical abilities, their procedural abilities. Okay. Supervising physicians, instead of seeing medical students as a liability, as something to kind of be swept under the rug that we don't want to tell people about. Okay, I know I have to get this person trained, but I just hope that I can do it without hurting anybody, right? To see them as an asset, to see the value that they can contribute. In interacting with patients, I think this kind of shift would involve a change away from obfuscation, away from the, this is student Dr. So-and-so, or worse, this is Dr. So-and-so, away from the so-and-so is going to help contribute to, or is going to do this exam now without asking permission, and toward honesty and transparency with patients. I think this type of approach, a more honest, more transparent approach, has the potential to allow us to see patients differently and their role in the process differently. So rather than looking at them as a guinea pig, we want to see them as a partner. Patients have a lot of perspective that can help with education of our medical students and residents. And we should try to incorporate them into that process as partners instead of just as passive subjects to be something done to. All right, if we can create this type of a partnership, I think trainees are more likely to experience their learning environment not so much as stressful, but as supportive, a place in which they are not feeling morally compromised, where they feel moral distress as a result of their participation, but instead are encouraged and supported in their learning process. And finally, I think as the end result of this sort of virtuous cycle could be that instead of ethical erosion throughout the 3rd and 4th years, which is a phenomenon that has been pretty well documented, that students' moral reasoning skills, that their attitudes toward various interventions with patients and things like that all decline. They all get worse during the 3rd and 4th year of medical school. We might be able to come up with an environment that supports ethical development. Okay. So it's my view that partnering with patients and sort of those things that come along with this paradigm shift opens the door for a patient-learner partnership that can benefit both parties. Now, what does that mean exactly? I think that's going to depend a lot on the individual people involved and the individual programs involved. I've heard all kinds of different proposals for this partnership, from asking for feedback. So to have a resident or a medical student ask, how did that go? What could I have done better? To sort of explicitly asking patients to participate in their care. There are a variety of approaches that have been proposed in terms of long-term follow-up with individual patients, right? Partnering one patient with one student so that they get to see longitudinal approaches with, or what happens to that patient longitudinally. Another approach is just what my initial student Osama wanted to do, which is just to say thank you, just to express gratitude, acknowledge the contribution and express gratitude. So I think there are a lot of different ways that we can do this. But in order for this type of approach to work, we do need policies to be put in place, expectations to be clearly set by institutions. Institutions also need to offer faculty development in this area. There's a lot of data to show that the biggest influence on medical students and on residents is not the ethics courses that I like to think are important in forming in their perspectives, but instead what their mentors do, what they see day in, day out in the clinic. Those of you who are familiar with the concept of the hidden curriculum, where there's this sort of explicit agenda that we supposedly teach our medical students, and there's this hidden curriculum that we are actually teaching our medical students and residents as we acculturate them into medicine. This is all kind of part of that same thing, that it really has to be the mentors who are the ones taking the lead on this. We shouldn't put medical students in the position where they feel like they have to choose between doing the morally right thing and compromising their grade or the respect of their attending or their physician, or their resident. All right. Those supervisors, those attendings and residents need to follow through in the clinic to make sure that they put those policies and that material that they've learned through faculty development in place. And finally, we need trainees to have the opportunity to practice. It's not something that comes that naturally. It's probably not something that they've seen or done before, talking to patients about feedback or getting their consent. How do you approach that? That's going to be something that each person is going to have to develop on their own. So it sort of is an authentic way of talking with patients about that. We should include this as an aspect of OSCEs, simulated patients, things like that, instead of just kind of pushing it aside and letting it be something that we think patients will figure out. Trainees will figure out. Okay, so I'd like to think that if we can try to be more honest, more transparent with patients, this can sort of lead into this virtuous cycle of partnership with patients, which has the potential to lead to a more healthy learning environment for our students. I do have one example that I wanted to share with you of what I see as sort of an ideal trainee-patient interaction that I think we could strive toward. During, again, one of my third-year clerkship sessions with the OB students, a student volunteered that he had been working closely with a patient who was pregnant and in the hospital for the end of her pregnancy. I don't remember the exact clinical reason, but she was in there for 10 days or 2 weeks or something like that. And he cared for her, was assigned to her toward the beginning of his clerkship, and then continued to follow up with her, coming in after he had moved on to a different part of the rotation, but would still come back, talk with her, really went out of his way to make sure that she had her questions answered. If she had problems or concerns, he would try to get the attention of the other members of the team, things like that. Really served as an advocate for her. And when it came time for her to be ready to deliver, she asked him to deliver her baby because she said he is the one who has given her the best care and who had made the biggest impact on her experience during those 10 days or 2 weeks in the hospital. And I think that, again, that's not going to be, results may not be typical, but I think that's the type of thing that we want to see more of. And we can only do this when we're honest with patients and when we really see the role of medical students and other types of medical trainees as a positive as opposed to a negative. So I think I may be finished on time. I have a bunch of references here that you can look at if you're interested up on the iTunes University. And I would love to hear any questions or comments that you might have. Yes?
If you go to the microphone. Are the microphones on, by the way? Check the switch on
I practiced for about 60 years as an anesthesiologist. And I just want to tell you that unless you are in a clinical research center, you still have to hear an attending surgeon talk to the patient, telling the patient this is his first time to do the procedure. And 60 years.
You have never heard anyone, an attending physician or anybody?
The other thing is that surgeons are very, very leery to tell their mortality and morbidity rates. For example, for a carotid endarterectomy, the accepted stroke rate is about 0.7%. If you have a neurosurgeon that tells you his mortality rate is 6%, look for another one.
But wouldn't that be material to your decision?
Of course, that's your choice as a patient.
Yeah. So is that type of information available?
They don't tell you their mortality statistics.
Right. Okay.
That's unfair.
Right. Good. Okay. So I think you're being sympathetic and saying that you haven't heard anybody actually being that transparent, but that maybe there's a reason we could consider that. Yes. Oh. I'm sorry.
I wanted to know how far do you extend the sphere of the medical team? Because what about trainees in other disciplines? You mentioned an EMT. I'm thinking of our students who might be coming from a background in philosophy or law, who are suddenly in the hospital shadowing somebody. How do we introduce these people who aren't medical students and explain the boundaries of their participation? How far do you take this in your head?
Yeah. That's an interesting question. I wouldn't think that there would be that many people who strongly object to the idea of saying, this is a philosophy student or an ethicist, they're just along to watch. Now, if I were going to go in and try to do a procedure, that would be different. But it seems to me that the patient has a right to know everybody who's in the room. And it's just a matter of politeness as well as, informed consent to explain to them who's there and what their role is. So I think I'd probably take it pretty far. Yeah, thanks. Yeah, go ahead.
My question was, as a first-year medical student, we actually had a lecture to discuss what we should say to patients when we introduce ourselves.
Great.
And it made it very clear to say you're a medical student. I had the same mentality of, oh, I'm a doctor now because I'm in med school, but that sort of got slammed down very quickly. And most of the physicians that I've shadowed have made it very clear, he's a medical student. But I'm curious, has there been attempts to train the faculty more than there has been the students, or a combination of both?
You know what, I've done a good amount of literature searching on this topic, and I have found nothing having to do with training of faculty. I don't think that is a common, I think people, once they sort of get out into the CME world, there's very little enforcement of what exactly, you have to learn something, but it doesn't really tell you what exactly you have to learn. So I don't know that there has been, to my knowledge. Yeah. Hi.
So sort of following up on the question before that, I have a PhD in microbiology, and it's horrible because it seems like I'm a fourth-year medical student, and it's a crapshoot on these rotations, whether or not some well-meaning resident or friend of mine who has gone on that I started in school with come in and introduce me to Dr. McIntosh. And maybe on infectious disease that was okay, but it's traumatic because then once they leave the room, I have to go back and explain that it's a PhD. So that was my first.
Right, okay.
I will comment that I haven't seen very many students at this university misnumber themselves as they come in. Most of them are pretty good about introducing themselves as medical students, or sometimes the student doctor comes up. But I did see one guy who was not trained at this university repeatedly and continually introduce himself as a doctor when I was on rotation with him. And he came from a different institution. I will tell you, I found it egregious. My follow-up to that is that I have found the attendings who are very forthright with who we are generally tend to be the attendings who have better rapport with their patients generally. And are the attendings that I train with most easily, that I'm more willing to ask questions of and to be more forthcoming about things that I propose as a trainee. So if you come in and kind of lie to your patient about who I am, I don't trust you as much either, because I know the why. So I have two questions. Do you find that there could be, or do you think there could be a correlation between personality traits or types and a willingness to go along with this? Because I find many medical students to be introverted and to be kind of capped into this system. And I'm a pathological introvert. And hello, my name is Megan McIntosh. I'm a medical student. It's just my introduction. And that's just how I start. So I'm just wondering if maybe introverted kids are more easily kind of sucked into this kind of behavior. I have one more question. I think about this a lot. The OBGYN rotation.
Yeah.
Was there a gender correlation in that study? Because our boys get rejected a lot when they say that they are medical students. The next thing that happens is that the woman says out. Yeah. And so I was just wondering if maybe that could be the reason why it seemed to go up after the week.
Yes. Okay. So I'll take the last. I'll work backward. Yes, there has been shown to be gender correlation, but again, the numbers are fairly small. Like male medical students do get refused more often. There was one study that I read that was very interesting that actually said that nurses and other, not so much attendings, but nurses and other people who might be the ones asking permission were more likely to actually say, when it came to males than females, you don't want a male student in here, do you? So like they would come back and say like the patient refused, but sometimes it was because they were kind of set up for that. So I do think that there is a bias against males, both on the part of patients and on the part of other caregivers. I do agree with you that it's partially a personality issue, like some people just naturally feel comfortable and confident enough in themselves to go in and say, yes, I'm a medical student, it's nice to meet you, what can I, please give me feedback, on my care that I provide, something like that. Medical students have spent their whole lives striving to be good enough to so that sort of taking a step back and being like, can you help me with this, isn't something I think that comes naturally to a lot of medical students. But I think that's the best argument for why we need to practice it and to be very clear about what we expect. Thanks. Yeah.
Hi, thank you so much for bringing attention to this issue. I just wanted to make a comment about an additional harm that I see, and I think it's because I'm a specialist and I work in the hospital, but I'm on service all year long. And so I see, teaching teams come and go, and I think that what I see commonly happen is that there's no acknowledgement of the end of a relationship once the team rotates off the service, and it happens with medical students, residents, or attendings, and I usually am the one to explain, once that transition occurs, to a patient who may have felt a real connection with the medical student, that, oh my gosh, what happened? Why have they abandoned me?
Yeah.
And so I think that another potential harm that can come of non-disclosure is that system is not brought out in the open, and the patients can actually feel some grief and loss and wonder maybe what they did wrong, because that relationship is ended without any acknowledgement of why.
Yeah. Yeah, great, thank you. That's a nice point.
We were in a circumstance teaching to ROD clerks several years ago. This is after Peter Euclid study. And I was under the delusion, like yourself, that of course this never happens anymore. And some of the students, they would often bring up other issues that were happening on the wards. And one of them noted, I'm really kind of troubled by this whole thing where I was called in while this woman was anesthetized and did this pelvic exam. Oh, really? Tell me more. And then I asked the other students of the 16 or 20 students, is this happening with you as well? Oh, yes, it's happening. So, and it's, we wound up having this become a question that was referred to us in the ethics meeting. And what we did was we redesigned the informed consent form in the hospital, in which any person, in order to be examined under anesthesia, had to give their consent. So if you were not a person who was specifically part of the consent form, i.e. the attending physician and the residents, who were part of the whatever it could have been prostatectomy, could have been TAH, BH, BSO, whatever it was, they had to say, And additionally, there's a separate one. These students who are, or residents, who are not part of your surgery are given my permission to perform an examination while I'm under anesthesia. And they would have to then sign it and check the little box saying that it's okay to do so. So it was made an explicit format. I did learn some things. So the GYN doc, who was part of the ethics committee of Health Design Reform, had said, I'm not going to let anybody be scrubbed in the room with me who doesn't know exactly what the pelvic anatomy is prior to me going in and starting that surgery if they're going to be holding a hemostat or a retractor. So therefore, every single one of them will be definitely doing a pelvic exam under anesthesia. And so I learned some new things. So I had some compassion of, okay, let me hear your perspective here. So that was a very important thing. So that's why we had to have some sort of a discrimination between those who are part of the operating team, which included the students, and those who are not at all, and really didn't belong there. But they were telling the typical story of having 5 people lined up outside of an OR while this woman was about to go ahead and have her hysterectomy because of 5 women.
Yeah.
That's one thing. So there can be fixes that can be semi-elegant to go ahead and repair this at this policy level. I did think briefly about your run-in with the risk management and wonder how would they respond to this. So in a story from my distant past, I was in a family medicine clinic where I worked with another attending physician, and his perspective was even more strong, let us say, in that if a patient said, I don't want that student, and sometimes every once in a while you'll have a patient who says, I don't want any students. And he would, told me later, he told me that he did this, that he would go in and he would say, so you're asking to be fired from my practice? Because I will not have any patient in my practice if you will not consent to have my students see you. And I said, well, Bob, that was his real name. Perhaps that's a bit strong, and perhaps we need to allow patients the right of refusal. They may have their own histories or their own fears, and maybe we need to take a different approach. So, what do you have in mind? I said, maybe something at the front desk. And so he allowed me to design, and it was later put in place, and it said something to the effect that the University of Far, Far Away is proud to let you know that far, far away medical students are here taking care of you and your care today. And so that was then put right at the front desk when they were checking in, and it was there for them to see and at least passively absorb. So at least help. So if people really had a problem with that, at least it'd be a discussion.
Yeah, great.
You said that the patient was put to sleep and there were 5 students who was going to examine the patient.
Yeah.
Was that discussed with the patient once he's still awake?
No.
That is assault.
Yes. We're in agreement.
Yes. There was an interesting article, I think Lewis Wall was the author, that came out shortly after the whole thing about the anesthetized, I don't know why I can't say that word today, anesthetized patients. Basically making that argument that a medical student who is part of the team and who is sort of legitimately participating as a member of the team didn't need to have special permission, but that beyond that it was pretty much unethical. I'm sort of interesting that they had the opportunity to consent for more students to do that. But I have to imagine it's a pretty small minority of people who signed that line. So thanks. Yeah.
These clinicians are getting up and offering helpful and useful advice, so I thought I'd stand up as a philosopher and be a troublemaker.
Great.
The concern, and this doesn't, I don't find this compelling, but the concern that I can see here is that I hear enough from third-year students that the stories about residents too, that, oh, we need to get this number of procedures done, I need to do this number of procedures, and so on. And they're having trouble getting them done during their rotation, during their residency. And I look at the numbers of people who refused having their first LP done, having their LP done by somebody doing the first, and that's going to cut that in half. Aren't we then not sufficiently answering that challenge. Again, it's not particularly, it's not a moral argument, but it's still a legitimate practical argument. We need to train our students.
Oh, I think it is a moral argument, yeah.
Yeah, so don't we still have that problem then, even at this point? What do we do?
I think it's hard to know. It would be really interesting to do a study where we have an institution that has a really robust disclosure policy and then a more typical one to see whether there is that type of a problem. We don't empirically really have evidence yet that that would be enough of a problem to, make it so that we're really substantially undermining medical education. I think there could, if it's done properly, I do think we might even get just as many people to consent because they feel like they're participating in something. If a medical student comes and sits down in front of you and says, I really, I'm trying to learn this, or this is my clerkship, this is my opportunity to learn this procedure, like, I'm wondering if you're willing to participate in my medical education, I think it's likely that we will get responses that are positive, if maybe not more positive, but maybe not automatically less than when the nurse comes in and says, oh, we have a medical student today, is that okay for them to do it? So I think that we might be able to sort of balance out. I guess that would be my hope, but we'd have to do an empirical study to find out.
Well, again, philosophers, we don't have to let pesky things like facts get in the way. What do we do if they, I think you're right. What do we do if we're wrong? That is, then we do in fact have a clash between, and that's what the challenge is saying, there's a clash between these two things that we value. Right. And you are arguing, I think you're right, that there really isn't. But what do we do
if there is? I think we might consider alternatives. Paying patients, that's what we do for research, right? We put patients at risk. Maybe that's going to make medical education a lot more expensive, but I think that considering it in the same way we consider the research model, in which we are explicitly asking patients to undergo research, we think research is important, and basically to take a paradigm closer to that than to our current approach. I don't know. If it added another year of medical education, then maybe I would start to say, like, the cost is too high. But until we have evidence that we have that kind of problem, I guess. But you're right, that is not a philosopher's.
You have the last question. Okay, thank you, I appreciate it. I'm Dave Wakeman, I'm the academic dean of the school, so my daughter's a philosopher, I'm not going to pay attention. I think the issues being discussed here are really relevant. It's one of the reasons when you go to the instructional building of any medical school, including ours, that we have large standardized patient clinics and we have large simulation centers. We recognize all that. I've undergone a couple of major surgeries in the last few years. One of the things is getting older, and you have to want to make sure the person has enough experience when they're doing something key. So it's a real consideration. For the Bioethics exam, we in the nursing school have routinely paid standardized patients to be patients to allow the exam, because in fact you want the patient to become familiar before the student to become familiar, before they're dealing with patients. So I think the issue, I agree with everything you said, and I think we have to do it in these ways. And I think empirical data would be very helpful in telling us how much more we need to do along the simulation or standardized patient group. Thank you.
Great, thanks. Thank you very much for the opportunity. I've enjoyed your comments.
Thank you very much.